It's my pleasure to introduce Dr. Sonu GOEL. He does not need any introduction though. A distinguished ophthalmologist and medical director at Anand Eye Hospital in Jaipur, which is one of the leading eye hospitals in Rajasthan. Known for his excellent live surgery and oratory skills, Dr. Sonu brings a wealth of experience in cataract surgery and a passion for advancing vision care. So he has always been on the forefronts of technology and has been using cutting edge technologies and premium lenses in his practice. So today he will be sharing his insights on enhanced monofocal IOLs and how does he place these IOLs in his practice. We will discuss the counseling, pricing and insurance aspects. So I think Sonu sir prefers to have a open discussion on this topic. So, sir?
So, a very good morning and thanks Sheetal for that nice introduction. I'm really grateful. And so, I think it's a wonderful design course and taking ahead, how do I place enhanced monofocal IOLs in my practice, counseling, pricing, insurance. So before we begin and before we talk of any product to the patient, I think we in our own self should be first convinced how good is the product in terms of the vision recovery and the kind of result that we are giving to the patient. So your own, getting your own self counseled first with the product is very, very important. You have a gamut of lenses which you can offer to the patients. So you can talk about trifocals, EDOFs, enhanced monofocals, monofocals, torics, but the patient understands which lens will give me the best result. So ultimately, as clinician, you might offer a basket to the patient, but what is important is what you want to offer and what you feel secured and assured of the results. The day this concept of advanced monofocal IOL came in, I think it gave us two big advantages. Number one, some kind of an additional benefit to the patient in terms of distance and intermediate, or maybe a kind of a vision where the patient will be able to do all his routine household works without the need of additions. And at the same time, we as practitioners who were practicing monofocals in a particular segment would step up to a premium, not exactly to that level of trifocality or multifocality, but somewhere in between. That's what I stage these lenses in my practice. So convincing your own self, because we have seen, and as Sheetal has shown, advanced monofocal IOLs would give you a very good distance and a very good intermediate, and once implanted bilaterally, fair near vision, where I would talk to my patient that without the need of an addition, you can do most of your household works, but whenever you are reading fine prints, you might require an add of 1, 1.5 or maybe 2 depending upon your own residual accommodation or your own ability in the retina. So enhanced monofocal IOLs, we all know, they have an advantage over the monofocals. They have a key benefits because they are giving patients the better visual outcomes. At the same time, there is no downside. So no halos, no glare, no starbursts, and ideal for patients who are seeking quality distance with minimal dependence on glasses. If you scroll through the market for the advanced monofocals, I think all companies have their own baskets, and Isopure by BVI, Raven from EMV, Vivenex Impress by Hoya, Aspire by Bausch & Lomb, Extend by Hanita, iHance by J&J. But I think going for a meta-analysis, if you see all these lenses fare well. Now what is the essence? Different lenses play differently, but the main essence is that the optics provide a higher order aspheric anterior surface with a continuous power progression from the periphery to the center of the lens, which gives you an add of intermediate vision. So this is, to quote, this is how a monofocal would look like, and this is what the advanced monofocal, you can see a central slight, where there is an kind of a profile which adds to your depth of focus. Short, but this lens that we have been using, Isopure from BVI, and over I think 500 lenses that we implanted in last 6 months has given us excellent results, and J&J iHance also on the same platform. But what differently did this lens for us was that it works for all range of refractive error, which The other lenses would not in extreme cases of myopia and hyperopia. So essentially, the extended range of vision that we talk is basically if you increase the depth of focus by approximately 50%, there is a 12% decrease. So if you decrease this MTF by 12%, the depth of focus increases by 50%, and that is where equivalent to an approximately a diopter of extended depth of focus. So that's the principle where these extended monofocal IOLs would work, and that is what gives you that kind of an extended range of vision. So we have known for ages the average spherical aberration for a 6.5 millimeter pupil on the cornea is plus 0.27, but this could vary in myopic from 0.024 and in hyperopic 0.034. So none of the lenses are customized depending upon the refractive error as compared to isopure, and this is how this delivers on the profile that the patients usually have. So if you see here, this actually varies depending upon the dioptric range. The corneal spherical aberrations are here, and this is the dioptric range, and where the competition available in the market would kind of balance this out. And this is how this isofocal technology balances the already existing corneal spherical aberration, and that is what delivers you the intermediate at all dioptric power. One good slide that I share from one of my colleagues is this dysphotopsia profile, and this is how a monofocal IOL, even for a 0.5 diopter of hyperopia, would behave, and this would behave even with a minus 0.5 diopter of myopia. Similarly, most of these advanced monofocal IOLs have a similar profile. So what I want to reiterate here is that if you want to do a kind of a micro monovision where you just want to make one eye for distance and the patient says that look, I want to see a little for near, you can mix and match of minus 0.5, and this doesn't actually disturb the doesn't create any kind of a photic phenomena. So the dysphotoptic symptoms would be almost similar what a monofocal IOL will end up giving. So it works very well. This is one of the papers in the Journal of Clinical Medicine, which talks about the enhanced monofocal intraocular lenses. It talks about the retrospective study, which compares the three basic models available in the world market. Essentially, the defocus curve with the IHANS, the Impress, and the Isopure, no proprietary interest here, actually almost balances and equivalent for all the three lenses here. The binocular contrast and the special frequency is almost equivalent. So that means the Technis IHANS, so the study concluded that the IHANS, the Impress, and the Isopure, though they may be based on different optical profiles, they showed similar results in terms of visual outcomes, the aberrometry, and the photic phenomena perception. But I think the outliers lies with the Isopure in the extreme range of myopia and hyperopia. So these represent an interesting option in the standard of treatment of cataract patients. So that is where our journey starts. So I think once we are convinced with the technology that we are using, yes, this lens is going to work, we have to choose who are the ideal candidates. So I, in my practice, would rarely find a patient with a big no for these kind of lenses, except patients with keratoconus or patients who have undergone hyperopic LASIK, or patients with abnormal corneal spherical aberrations, and rest all those patients with retinal disorders, with glaucomas, with abnormal corneas, they're all candidates where instead of a monofocal, you can always go in and chip in for an advanced monofocal IOL. So I think the patient exclusion criteria stand almost similar to the monofocal platform. So whenever I talk to my patient, I usually counsel that, look, we have three baskets of lenses or options available. One of them would give you distance, intermediate, and near, that in routine you will not be requiring glasses. That's a trifocal lens. But the downside is whenever you drive or sometimes in bright light, you can have those starbursts and glares and halos, but it is not necessarily that you'll have maybe 1 in 100 patients who doesn't have good neuroadaptation, or there is some phenomena, you might have that. So patients who are active drivers or type A personalities are excluded. The second range would be EDOF lenses, and these EDOF lenses, where we say that once you have a bilateral implantation, you will have mobiles and your routines screens, you'll be able to see without glasses. But whenever it comes to fine print, you might need an ad of 1.5. But that's good in driving. And the third would be the advanced monofocal. So we nowadays in our practice do not talk of monofocal IOLs, but we have stepped up. So at least stepped up by 20% of the revenue or the pricing of a monofocal IOL. So we step up by 20% of in this segment of advanced monofocal IOLs. Whenever we are talking of the insurance here, we would always bill or take the permission in terms of the advanced monofocal IOL, and where the billing would be at least 20% beyond the normal monofocal pricing. So that helps in two ways. It gives you that extra revenue generation. It gets you off the routine package system which the insurance has given you for a monofocal IOL, and you can charge over an extra to the patient under an undertaking that they have got a procedure which is giving you a good distance and a good intermediate. And the patients are also happy. Recently, I saw a patient coming up, operated at some other place, had a cystoid macular edema, was scribbing, but then he showed, look, the doctor gave me a very good lens, and this, they say, is an advanced form of a lens which is called advanced monofocal. So that patient was in fact teaching me, and that was what was very enlightening, that the patient also understands that this is different from a routine lens which is being implanted everywhere, and the lens I've got is a little advanced form of a lens. So I think all in all, it can be a game changer in our practice. You can push up your revenue with this lens. So actually over a 3-year period in my practice, now monofocals have almost died out, and we have converted the entire gamut into the advanced monofocal IOLs. And the patients are also happy. Once they have a bilateral implant, most of their need for the glasses withers off. So I think a good communication and education with the patient, simplifying the cost-benefit explanation, usually visual aids to demonstrate the differences, and offering the finance and payment plans to these patients actually in the initial days converts. But once you have a certain population who has then that itself becomes a self-driver for most of these patients. There is a lot of market demand for premium lenses and the patient expectations. So, but with this segment, since the patient has not paid a huge premium, but this lens still stands as a premium lens, so the expectations are not that high because they have not given you a lakh and above, which usually happens whenever you are doing a trifocal or you are doing a femtocataract with those trifocals read-offs, where the billing would shoot up to 1.5 and the patient expectation would be like they have a magical vision. So the expectation vis-a-vis cost, vis-a-vis payment is all taken care with these kind of, this kind of segment. So I think balancing the affordability and the profitability and a high patient satisfaction with these lenses is what stands in my practice. A lot of studies which actually talk about this. So how to implement this? You train yourself, you be convinced, train your staff on the new offerings. You should have visual displays, update your marketing materials and the websites, talk about advanced. So patients are more thrilled to listen words like advanced, pro, plus. These are those catchy words which go with the phones and the market, providing patient brochures and natural online resources. So I think that's the way to go, and that's the way to push up our practice. Thank you, Sheetal.